An important section with this GA chapter is the repair of hernia. I hope all of you understand what is hernia. Anything that prolapses is called as a hernia. Coming to the coding of hernia, you should understand what is a type of hernia the patient has. There are so many types as inguinal hernia, femoral hernia, spigelian hernia, umbilical hernia, ventral hernia, etc. So while coming to the coding of this hernia, we need to know what is the type of hernia that is being removed, because specific codes are there for the specific types of hernia, and you need to know whether it is a reducible one or a non-reducible hernia. The hernia, if the physician is unable to reduce it, it's called as a strangulated or an incarcerated hernia. What happens with this? With this chronic incarceration, the patient can develop a gangrene and that might result in a shock. So this condition has to be treated. Patient will also start having this pain and other abdominal symptoms. Thirdly, you should know the age of the patient. So first being the type of hernia, and second you need to know whether it is reducible or non-reducible. Thirdly, you need to know what is the age of the patient, and fourthly, you need to know whether it is a first time, is it initial or is it the recurrent hernia, and most importantly you need to know whether there is placement of a prosthetic device like a mesh. While coding this hernia, we'll have to code for the mesh placement, which is an add-on code. And please bear in mind, mesh placement has to be reported only for incisional and ventral hernia and not for any other types of hernia. When the diagnosis is a ventral incisional hernia, it is reported as incisional hernia. Though it is ventral, actually it is a complication of the surgery. So it is an incisional hernia. So please bear in mind, though there is extensive documentation of a mesh placement, we are not supposed to report it for an inguinal or for femoral hernia. This needs to be strictly reported only for incisional or ventral hernia. So here are the steps that we need to follow. First is whether it is reducible or strangulated. Next, is it initial or recurrent? Third, see the age of the patient. Fourth, the mesh placement. And fifth, if they are placing any omentum on top of it. Because if omentum is placed, omental flap is placed, we can report that as separately. Again, harvesting of omentum, we can report that as separate codes, whether even as an add-on code or as a primary code. Again, this omental harvest, if they are placing it in the abdomen, we have a separate code. If they are placing it for any other procedure other than the abdomen, say they might be doing some thoracic surgeries, in that case you will have to report the code for extra abdominal. And lastly, you need to understand what is the type of hernia. Is it open or laparoscopic? If it is going to be laparoscopic, the code sections are pretty simple, because you have one code might have the repair of so many hernias, and here the mesh placement is bundled. You are not supposed to report the mesh placement separately if the hernia repair is of a laparoscopic nature. The code selection in a laparoscopic approach is purely based on whether it is reducible or strangulated. You don't even have to take into consideration the age factor.